Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
Today's talk is presented by Paul Miles, head of Alfred Health's and Monash University's Department of Anaesthesia and Perioperative Medicine.
I'm obviously very proud to present the results of this study and perhaps more importantly to explain why we did it and what I believe we've clearly demonstrated. I do want to acknowledge our National Health and Medical Research Council in Australia and the Australian-New Zealand College of Anaesthetists that funded this project, as well as the Health Research Council in New Zealand. The paper was published a month ago, and I checked the other day, it said 78,000 views, so it does show that these sort of journals give it immense, I think, impact in terms of access to new studies. And obviously I want to acknowledge the work of all the co-investigators and other co-authors on the paper. So this was truly an international trial, a lot of patients obviously from Australia and New Zealand, but also a lot here in the UK. And the UK arm of the study was led by Gary Minto down in Plymouth, and I want to particularly acknowledge him and all of any of you who are involved in the study as well. The trial is therefore, I think, quite generalisable. We enrolled patients in quite different healthcare settings. Many obviously were big academic centres, but equally there's a lot of DGH and smaller hospitals throughout the world. I think all of you appreciate that in the last decade there's been this push or this move towards a more restrictive fluid approach in all types of major surgery, particularly GI and particularly colorectal surgery. And a number of small trials have supported that would reduce complications overall and reduce hospital length of stay. They are the two positive findings. What you probably don't appreciate, in fact, is that there's been quite a few other randomised controlled trials that could not demonstrate any benefit of a restrictive fluid approach, and some randomised trials, in fact, demonstrated harm. Nevertheless, this move has been afoot. I've come to this conference quite a few times in the past. I read the literature. My personal view has been that we have used too much fluid, at least in the past, and I have generally used less fluid myself in recent years. And there's this consensus around this idea that patients should be maintained near a sort of a zero fluid balance in particularly major abdominal surgery. So that was effectively our study hypothesis, to test whether or not a restrictive fluid approach in patients undergoing major surgery would reduce complications and hospital stay, but perhaps most importantly, therefore, improve disability-free survival out to a year after surgery. We enrolled a broad range of patients having abdominal surgery. It was international, multi-centre. We obviously couldn't blind the anaesthetist or staff looking after the patients, but what we did do is we fully blinded all the outcome assessments, particularly the longer-term disability-free survival. And the regimens in the study was to give roughly 5 or 6 litres both intraoperatively and out to 24 hours in the liberal group and half that in the restrictive group. They were randomised to either of these arms at induction of anaesthesia, traditional practice. Patients and anaesthetists were asked to give around about 10 mils per kilo at or around induction to sort of get a fair bit of fluid in to catch up with whatever fasting periods and vasodilation of anaesthesia and so on and so forth. During surgery, run 8 mils per kilo per hour, at least for the first 4 hours, and they could drop it back if they felt there was no need to give a rate at that high. And as I said before, roughly half of that in the restrictive group. We allowed other colloids or blood transfusion as clinically indicated. If there was strong clinical reason, there was a suspicion by the anaesthetist or any other staff caring for the patient that the patient was a bit under volume, that in either group they could give additional fluids. And if there was a clear clinical indication that the patient was getting too much fluid in the liberal group, they could cut back that fluid. So there was that discretion built into it. But all we asked was that there was clear clinical reason, not just that's what you normally do or your own gut instinct was telling you. So it was a pragmatic trial. All other areas of surgical and anaesthetic perioperative care was routine local practice. You did what you normally do. The only variable that we controlled was the amount of IV fluid they were given. And at the same time, we encouraged everywhere So, these existing or current ERAS principles and guidelines of care in terms of both fasting, early mobilisation, opioid-sparing techniques, so on and so forth. So they were built into the protocol and the procedures manual. Now, I love this diagram. Mark Bellamy, in an editorial in BJA back in 2006, this idea of this sort of U-shaped curve where I think it's clear to all of us, if you give way too much fluid, you're going to cause problems. If you give way too little fluid, you'll cause problems. And there is this kind of Goldilocks or sweet spot. And this diagram and this concept's being used by people who like goal-directed devices to help individualise and find what that is for that person. And I think that's reasonable. And we designed our trial so that we weren't out on the edges of this curve, that we were actually somewhere in where we believed was somewhere in that nadir or at the bottom end of it. We just didn't know exactly where it sat on that x-axis. Pleasingly, in the study, I haven't counted them, but there must have been close to 1,000 or more anaesthetists around the world who individually cared for the patients in the study, and also an even greater number of nurses and intensivists and other doctors on the wards. And they followed the protocol, I think, amazingly well. We actually ended up giving really exactly the amount of fluid that we had designed in the protocol. This is quite extraordinary for what really is otherwise a simple, diverse, randomised trial. So there was a clear positive fluid balance in both groups, including in the restrictive group. I want you to keep that little bit in mind. These are for the patients, also sort of weight gain, roughly nothing in the restrictive group, so obviously no big fluid retention, if you like, a little bit in the liberal group. It's a large randomised trial. By the law of large numbers, you will equalise all baseline variables. You can measure them or not measure them. They will equalise perfectly as you approach infinity. In fact, if you do a trial with 1,000 participants, you effectively get complete balance on all variables. So it's something you don't get in a small randomised trial. So we had very good balance in the studies. We also had a diverse range of types of surgery, and those types of surgery, again, were also balanced between groups. Roughly half the patients had a fully open procedure, others either had a laparoscopic or lap-assisted. Now, we only included more major surgery, so it had to be surgery expected to last at least 2 hours. So we're not talking about lap collies and other more minor procedures. And these are some of the baseline factors we collected. There's actually a lot more of these in the supplement of the New England Journal paper. And again, very good balance on all characteristics. So our primary outcome, there was no statistically significant difference. So a restrictive regimen did not improve disability survival out to 1 year after surgery. The point estimate, the hazard ratio of 1.05, suggests that there's a 5% increased benefit or disability-free survival for the liberal group. That's where the so-called trend was, but again, clearly not statistically significant. And this is a plot of those data, again showing no difference. Just look at that separation that seemed apparent around 90 days, but disappeared in the final 6 months of the study. That's taught me something which we might talk about. So these are some of the pre-specified secondary complications in the study. The important ones, and the most robust, of course, is acute kidney injury. No matter how we look at it, there is nearly a doubling of risk of acute kidney injury in patients who are in the restrictive group. Now, I keep saying restrictive and liberal, but in actual fact, the restrictive group was a zero balance group. The liberal group is a traditional care group, the sort of thing many of us have been doing for decades. There was also a significant increased risk of surgical site infection. Along with the AKI, there was a higher need, although rare, for renal replacement therapy out to 90 days after surgery. And although there was a statistically significant difference on the day 3 quality of recovery score, me, the developer of the score, would state that that's not of any clinical importance. So it's just a statistical sort of difference, not a clinically important difference. And look now at mortality at 90 days. The p-value is not less than 0.05. It's an optimised p-value, Rupert. I don't know whether it's true or not. It would be consistent with some of the serious complications that occurred. But again, the numbers were very small at that point. And we looked at acute kidney injury more closely. Now, we did not include the more minor increase in creatinines, the stage 1 KDIGO criteria AKI. These are a doubling of creatinine or worse. So this is genuine acute kidney injury. It's consistent clinically with the pattern right through the perioperative process. They started off with equal creatinines. They tended to have slightly lower perfusion pressures, very slightly lower, certainly less urine output, certainly higher rates of oliguria or anuria, and then, of course, the AKI and even renal replacement therapy. Now, the surgical site infection, I was asked actually by just a colleague, part of the investigator team, with the less fluids and perhaps less tissue perfusion, are all the surgical site infections therefore superficial because of skin perfusion and so on? In actual fact, that wasn't the case. These are organ space infections. They are very serious and important and expensive infections to deal with. I mean, obviously, all types of SSIs are affected, but that's where most of the difference is happening, which I think is interesting. Now, what no one knows in the room just yet, including my co-authors, is I actually asked our statistician just the other day, look, can you just pull together all the serious complications? Because that's the studies that have been published in the past. Those small trials that I mentioned earlier on just pulled all sorts of complications. I mean, I hate serious complications. They're not coherent generally, but nevertheless people do it, particularly in surgical studies. So we pulled death within 90 days, the severe septic complications like SSI, pneumonia, and straight sepsis and so on, AKI, anastomotic leak. We also pulled, this is confirmed myocardial infarction, stroke, PE or DVT, and any adverse event that was rated by the local team as severe. So that could be a few other things as well. So when you pull those together, in fact, there is a statistically significant increased rate of serious complications in the restrictive group. And I've got number needed to treat here, but it's actually number needed to harm. So by practicing a zero balance in the previous definition, or more restrictive approach, there is net harm that 1 in 24 patients will actually suffer a complication that they might otherwise not have suffered. We, as I said, recommended ERAS. Sites do or don't use goal-directed devices, and I'm sure many of you would like to know how that affected or changed the result. So we now come to this wonderful subgroup plot or forest plot of you often see in many randomised trials, and I'm going to talk about statistics for about 30 seconds, so brace yourself. So I find this, as a clinician, an incredibly important source of information in any study. So you need to understand what it's showing you and what it means. So what you do is you have the full result at the top or the bottom of the plot. You then break down according to all the different categories or clinical factors that you yourself might think, does this result apply more in older people or younger people, or higher risk or lower risk, or longer cases or shorter cases, or particular types of surgery, or in different countries, etc., etc. And you can slice and dice it any way you like. Ideally, you should do it in a planned way and pre-specify them, because as you know, if you keep doing p-values, you pick up some that are just pure spurious. So those categories then are tested. Is there a difference within any individual category? And that's called a p-value for interaction. And if the p-value is less than 0.05, then there is a statistically significant variation of effect on that particular category. And you can see in our trial there were two features where in fact there was some variation of effect in it. And in particular, there seemed to be a gender or a patient sex effect, but when this was drilled down, it was not statistically significant, so therefore you can't conclude, are the effects stronger or weaker in men or women. Interestingly, New Zealand did, in fact, have a higher or a worse disability-free survival in the restrictive group. And that was clearly statistically significant. I still don't believe the result, though. I get a bit worried when you start doing secondary p-value testing. You can pick up some spurious findings. We went back and looked at the New Zealand data. We looked at the baseline balance in all the patients. We looked at the other characteristics, and there was nothing in it that suggested to us that that could explain the finding being different to anywhere else. And most importantly, the actual number of events or the number of cases was actually very low. So again, more likely to be spurious. But nevertheless, don't let a New Zealander tell you that restrictive fluids are good. So what if they did or did not use a goal-directed device? Absolutely no difference. So the findings are relevant in anaesthetists or hospitals that do or don't use goal-directed devices. But a goal-directed device will not protect you against the harm that comes from a restrictive approach in our study. And looking at acute kidney injury, the same sort of thing. There was no variation of effect in all circumstances, all the same. We were also asked, well, hang on a minute, you didn't do ERAS properly. If you had have used a full ERAS or more ERAS, surely that would have changed the findings. So we were asked by the peer reviewers of the journal to actually defend that position. Well, we could defend the position because we collected the data on whether or not patients, how long they were fasted for, whether they had a nasogastric tube or a drain tube, whether they had an epidural block, all those features that make up a good ERAS program that I still completely believe in. When we looked at those, the p-values for interaction, no difference. Results apply equally on whether you use ERAS or not, no different. Interestingly, you might have noticed there is a p-value that's less than 0.05, and this suggests that if you have a drain tube inserted, or if you don't have a drain tube inserted, you in fact have a higher risk or poorer disability-free survival. ERAS is out the door. It is not an explanation of the findings. So what are our major findings? In patients undergoing major abdominal surgery, a restrictive IV fluid regimen designed to achieve zero balance during surgery and out to 24 hours after surgery did not reduce serious complications or hospital length of stay, and it did not improve disability-free survival. However, that restrictive regimen is associated with a higher risk of acute kidney injury and other serious complications. And if you're using any sort of fluid responsiveness monitor, a goal-directed device, the effects do not change. If you are a high-functioning ERAS hospital or not, the results do not change. They apply equally in both settings. Now, I guess one thing that's struck us, and Ronaldo Bellomo, who's an expert on critical care and kidney injury in critical care, and certainly myself and others on the team who are kind of fascinated by this whole concept, is, well, what is perioperative or post-operative AKIs telling us as anaesthetists? We've got a fair idea of what's telling critical care physicians. There is strong correlation between higher rates of AKI and terrible outcome following critical care. But what is it like in the perioperative setting? Is an increased creatinine really of any importance, or is it just a surrogate marker of something that the patient themselves won't personally experience and may actually just be a transient thing that all comes good? Now, there's a lot of data that would suggest that's simply not the case, that in fact it is a serious signal of longer-term kidney damage. In other words, you get not just transient kidney injury, but you get permanent nephron loss. And it's correlated with chronic kidney disease. Now, that at this point is a hypothesis. And we are going to look at our data set now and go back to NHMRC, ask for another $1 million, which they'll happily give us, and we're going to follow up all 3,000 patients out to beyond 3 years after their surgery, and we will have that longer-term data that I think we all need to perhaps better inform the full meaning of the RELIEF trial. So what, in my view, and what is the data telling us about what is an optimal fluid regimen for major abdominal surgery? Well, in the past, it's been classified as a restrictive, a balanced, and a liberal approach. And as I said, we labelled our groups as restrictive and liberal. The restrictive group got around about post-operatively just over 2 litres per day over 24 hours, and the liberal group 3 litres. But in actual fact, I would argue strongly that our restrictive group was actually a zero balance group. And if you look at the numbers and do the maths, that's exactly what it was. So our conclusion is that a moderately liberal fluid regimen for major abdominal surgery is the optimal approach in major abdominal surgery. That does not mean excessively liberal. It doesn't mean all bets are off and you turn up the drip and away you go. It just means give more than we've been perhaps using in the last number of years, but not massively more. But certainly feel free to give a fluid challenge, a fluid bolus, and keep them on the healthy side away from dry. And there's a little regimen there, but the simplest way to remember it is this great, lovely, magical number 3 that I've come up with. Okay, it was roughly a 3-hour operation on average. The median was 3.3 hours. So you give about 3 litres of fluid during the case, and you give about 3 litres of fluid over 24 hours after the case. That's all you have to remember. Thanks very much.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.